Hi everyone, this is Mr. Neil Reiter, consultant audiologist and director of ClearWax. Thank you for joining me in another demonstration video of our recently developed WAXscope, which is due to be launched hopefully in the next month, early December 2022, but if not, by the end of the year. And we just have a client here who attended with bilateral occluding earwax and sticky dead keratin. We're just commencing with, I think this was the patient's right ear. Yes, it is. We can tell by the cilia on the left hand side of the first canal, first bend of the canal, should I say. So I'm just using our 4.25mm speculum to dilate and straighten the ear canal. We have got three other speculum sizes. The smallest one is a 3.5mm and the two larger ones are a 5 and a 5.7mm. Myself, I think that the 4.25 is going to be the most commonly used one, but we have got sizes for everyone, depending on their preference. I just went in with the Jobson horn there because it was quite sticky. I just wanted to see if I could scoop it out, but it was actually just spreading the wax and dead keratin like butter on bread and toast. So I've just gone back to performing microsuction, and you can see it is just blocked my suction tube there. I'm just trying to peel this off the canal wall. I'm just trying to detach it. I think eventually, however, I do use the Jobson horn to scoop it out because it was just going to take too long, as you can see with the sucker, because it's coming out in little bits only. That's despite me using some olive oil spray to try to bind and coagulate the wax and keratin together. See, it's just tearing away in little pieces. So we've all, I'm sure, performed these type of procedures where it's just a bit laborious. So I've just gone back in with the Jobson horn. I'm trying to get in and behind. I've just got to be careful. I don't want to make contact with the bony part of the ear canal. And I'm just scooping this out now. So it's just got trapped at their entrance, which is slightly narrow. There we are. I'm just managed to remove the K&B bolt now. Ear canal's more or less clean. I'm just going to mop up around the edge and at the base there. And you will see that this patient's got quite a severely retracted eardrum, especially posteriorly. And I'm going to circle it in a moment, but the posterior part of the eardrum, so the back part, is severely retracted and it's wrapped around either the head of the stapes, which means the lung process of the incus is eroded, at least the lung process. It could be the entire process. The entire incus is eroded, including the body of the incus and the short process, or it's wrapped around the long process of the incus. It's a bit hard to tell. You'll have a good view in a moment. So I'm just going back in, just see how narrow the ear canal is at the base. It's like a valley, and that's the skin is just getting trapped in the valley. So I'm just peeling it away. It's really, really sticky and gooey. There we are, I've just managed to peel that away. And just some residue just at the back part, so just going back in. So with the wax, you can see it provides a really magnified and clear focused view. So I'm just going to stretch and dilate the ear open. So that's the patient's eardrum, because it's quite tympanosclerotic. It's also retracted in the attic. Just getting it in focus. And I'm going to circle it in a moment. I suspect that is the long process of the incus and not the head of the stapes. The head of the stapes is very circular, but it's a severe retraction there. The patient's never been seen by ENT. They have got a hearing aid for this ear, and tympanometry confirmed a blocked eustachian tube. So we sent a referral to ENT by the GP. So this is their left ear. This eardrum was also retracted. I wouldn't say it's as retracted as the right side. The right side is quite severe, but nonetheless it was retracted. So again, it's just blocking the tube. When the patient arrived, they actually performed the procedure the other way around. So I started with this, their left ear, and then I reverted to the right. But for the purposes of the video, I decided to show the right first because of the interesting eardrum. So I've just put some more olive oil spray. So the olive oil spray that I use, it's produced and manufactured by a company called Clear. They recently appointed myself as their healthcare advisor, and we've got some other products as well. So they've got a Clear relief spray, which is designed for people experiencing inflammation of the ear canal, a bit of pain. It contains glycerol, which helps to withdraw fluid, water from the ear canal, so to reduce edema, swelling, and also lidocaine, which is a surface anaesthetic. Dentists typically use. They use it in terms of injection, but you can also apply it. So it helps to ease and numb the ear somewhat to reduce any pain. And the olive oil spray. So the olive oil spray, I use it quite a lot during procedures to help bind the wax keratin together. It makes it easier to remove. Also reduces the number of blockages inside the suction tube because it lubricates the inside of the suction tube too, so it helps the wax travel up the suction probe whilst vacuuming. So just a bit of keratin there again. So they have got the canal itself is quite narrow, and once you dilate it, the canal just widens. So I'm just using the Jobson horn again, trying to get in and behind, but similar to the right ear, it was just spreading this stuff, sticky keratin. It wasn't removing it, it was just spreading it and lathering it at the bottom of the ear canal. So actually had in some respects made it a bit more difficult to remove using the Jobson horn. So I'm just lifting it off and away the bottom of the ear canal. That's a kind of a good view of the narrowness of the ear canal, so that's why the speculum can really help to stretch and dilate. You can't over-insert the speculum into the ear because it's got a flared proximal end. So similar to your normal microsuction specular, so your Gruber or your Share or your Tamarkian, it's got or Rosen, it's got a flared proximal end, so it kind of stops you from over-inserting even if you're wishing to. We're getting quite a few inquiries about the WAXscope, which is great. And if you are interested, please do email info@clearwax.co.uk. One of the things that we get asked are the differences between the WAXscope and our flagship product, the iClearScope, which is still available. The iClearScope, in terms of view, the optics, you just can't compete with an endoscope in the ear. It's like you're inside the ear when you view via an endoscope. It gives you a panoramic view, a wide field of view. But an endoscope is more quite difficult to learn to use. Once you've acquired the skill, there's nothing quite like it to removing wax. But we have noticed a lot of specialists do struggle to use an endoscope. Therefore, the WAXscope was developed as the next alternative. The view with the WAXscope can be comparable to an ENT microscope when removing wax, and you can see we've got a speculum attachment. So that does all the straightening and stretching of the ear canal. With an endoscope, you don't have a speculum, so we're having to use the endoscope itself, the shaft of the endoscope, to the rod lenses to stretch and widen the ear canal. I previously used loupes before, and I really struggled to see very deep in the ear and the eardrum. It wasn't a very magnified view, and the body posture, having to constantly move and reposition. I used to lose focus a lot, so with the WAXscope, it overcomes all of those difficulties. You've got great magnification, focus. You can just change at a swipe of a finger. You can see the eardrum as well, and you can change the focus. So the patient's got an attic retraction, and there's a bit of keratin there actually embedded. Now we removed that. You're going to see him in a moment. So I'm going to, again, this bit was a bit more bendier. I'm going to just dilate the ear canal. There's the attic. So I'm just going to use a fine end suction probe. We're going to go in there and we're going to remove it. Now, there was still some residual keratin there. It was just staining. It wasn't something you could remove. It wasn't a plug of skin. But with the keratin is sticky, and you can see the residual keratin's there. The attic was self-cleansing, but we have obviously referred the patient onto ENT regards to the right, and they can obviously examine that ear, but there's no, fortunately, there doesn't seem like there's going to be a buildup of a keratin plug there to form a cholesteatoma, because we removed that keratin from there. And as I said, the residual mass is sticky staining, so it is fortunately not building up. It probably would be building up, but we managed to remove it today. So again, just going at the bottom, it was just sticky, blocking the tube. I hope you enjoyed that video, and once more, if you are interested in the WAXscope, please do email, or the iClearScope, please do email info@clearwax.co.uk. Thank you, bye.